So I'll be talking on intermediate uveitis and Enigma. Let me start with a case. This patient came from Tanzania, a 46-year-old gentleman with dimness of vision. He was a known diabetic and hypertensive. His HbA1c was 11.6. He complained of blurring of vision in the left eye. Anterior segment, there are flare cells in the left eye in the anterior spillover anterior uveitis, vitreous cells 2 plus, vitreous cells 1 plus. And this was the fundus picture of the right and left eye. Right eye is clear. Left eye, you can see the diffuse vitreous cells. And OCT showed left eye cystoid macular edema. What the patient was having was intermediate uveitis with spillover anterior uveitis with cystoid macular edema. He has got uncontrolled diabetes. We advise intravitreal injection of Ozurdex and topical steroid in the left eye. This is often the scenario of intermediate uveitis, and which present with pictures of dimness of vision and floaters. Intermediate uveitis, according to the Sun classification, inflammation that predominantly involves the anterior vitreous, peripheral retina, and the pars plana of the ciliary body. Pars planitis is a type or subset of intermediate uveitis in which snowball exudates in the vitreous and snowback formation in the pars plana. There is no association of systemic disease in this subtype of intermediate uveitis. So according to the Sun classification, which was published in American Journal of Ophthalmology 2021, there are 3 types of intermediate uveitis. One is a pars planitis type, second is a non-pars planitis type, third is associated with multiple sclerosis. So it appears to be about 8 to 22% of all uveitis cases. We saw about 1 in 5 of the uveitis in Shankar Nethralaya due to intermediate uveitis. Pediatric is a little bit more, 16 to 13% of all pediatric uveitis cases. 80% is bilateral. Mean age of presentation is third decade. There is 20 to 30 years. Average age is 23 to 28 years. And this is what is the pars planitis, the subtype of intermediate uveitis associated with snowbank. It's usually idiopathic. What are the symptoms? Main symptoms are floaters. There is a painless blurring of vision, but there can be a dramatic vision loss due to the vitreous hemorrhage, particularly in the children. Cystoid macular edema can show gross dimness of vision, disc edema. Pain can be associated with secondary glaucoma. There is usually a quiet eye. They can have band-shaped keratopathy with a chronic intermediate uveitis, mild anterior chamber reaction. One can have mutton fat kerattic precipitate, particularly in the sarcoid TB variant of intermediate uveitis. Peripheral anterior synechiae, posterior synechiae can be seen sometimes, and there can be secondary glaucoma due to the inflammation or steroid-induced. Posterior segment, what you see is the vitreous cells and strands, mild to moderate vitreous cells, snowball opacity, snow banking, retinal vasculitis, and peripheral retinal neovascularization, sometimes particularly in the children. And here you can see the classic vitreous strands and cells, and this is seen in the vitreous cells in the anterior vitreous space. And then signs of the CME and the sequelae retinal vasculitis. Retinal detachment can occur sometimes, and disc edema as is shown in this picture. What is commonly seen in 25% cases, dull foveal reflex with cystoid macular edema, which can be elegantly demonstrated by optical coherence tomography. Only self-limited is 10%, and remaining 59% smoldering and recurrent in 31%. So don't tell the pars planitis patient that you've been cured by the temporary resolution of inflammation. It can be smoldering or recurrent. Systemic disease associated with are sarcoidosis, tuberculosis, multiple sclerosis, and Lyme disease. And we published a series of cases of intermediate uveitis due to sarcoidosis. Mean age was 42 years, bilateral and majority. Female were more common than the male, and good results with the oral steroid and or immunosuppressive agents. We also described polymerase chain confirmed mycobacterium tuberculosis, intermediate uveitis, the analysis of 22 eyes. And this is one of the presentation. The patient presented with a broad posterior synechiae We might be thinking that this patient having anti-uveitis alone, but vitreous examinations in the indirect ophthalmoscopy showed peripheral vitreous red exudates with this peripheral vitreous multiple exudates in both the eyes. And this case in the vitreous specimen was positive for the mycobacterium tuberculosis DNA both by nested and real-time PCR. What are the differential diagnosis? Muscular syndrome, particularly intraocular primary vitreoretinal lymphoma, which you might be very careful about it. Toxocariasis rarely yields disease and amyloidosis. This is one case of toxocaria peripheral scarring in the retina, and there is a strand coming from the vitreous condensation in the periphery to the posterior pole in the optic disc. And this is a patient only strand of opacity in the vitreous cavity. Vitrectomy specimen showed congruent specimen positive, suggestive of amyloidosis. And this was the primary system non-familiar amyloidosis of the vitreous. Vitreoretinal lymphoma can present in recalcitrant intermediate uveitis. Here the vitreous opacity is coarse and large, and they can have aurora borealis signs along with the vitreous cells. There is a vitreous opacity is seen. What are the investigations we should do? We should do a complete blood count in ESR as we do in all uveitis cases. Chest X-ray, high resolution CT chest in particularly we do here. Mantoux test, angiotensin converting enzyme, quantiferon TB gold test, and of course syphilis to be ruled out with VDRL or RPR and TPHA. This is an example, some cases. This is a 25-year-old female with vitreous opacity as is seen in this picture, focusing behind the lens. Is it due to TB? Yes, it was found to be due to TB. HSCT chest showed pulmonary parenchymal infiltrate, and real-time PCR of the AC tap showed 2,204 copies of the mycobacterium tuberculosis DNA. And this is a patient of intermediate uveitis. HSCT showed bilateral symmetrical hilar lymphadenopathy suggestive of sarcoidosis. What are the ancillary tests is required in intermediate uveitis? It include FFA, UVM, and OCT. Nowadays, I am doing FFA in very many cases of intermediate uveitis, and this is one of the cases where you can see the hot disc and the capillary farning. Although the capillary farning doesn't go off with the treatment, but the hot disc is good as a sign of inflammation. When do you do UVM? When the pupil is small, cataract precluding the view of the peripheral fundus, you can do the UVM. You can show the exudates in the pars-plana region, which responds to the treatment. Optical coherence tomography we should always do when you see the dark foveal reflex or the near vision is less than N6, and you can see elegantly demonstrate a cystoid macular edema with thickening of the retina as well as the cystic spaces in the macular area. What are the guidelines of treatment? How do you manage it? It depends on the intraocular inflammation, cystoid macular edema, cataract, vitreous opacity, retinal detachment, and vitreous hemorrhage. Most cases are mild, respond to polyocular steroid, but we followed a modified Kaplan's approach. We give the posterior subtenon and the initial space, oral prednisolone, second step immunosuppressive agents, and third stage and finally vitrectomy. So posterior subtenon injection, triamcinolone acetonide, a posterior subtenon space is given, and it's given in the superior temporal quadrant, and this video is not working. In the oral steroid is required in bilateral cases, and some people given even in the unilateral cases. Failed periocular injection, it should be given 1 milligram per kilogram of the body weight, taper 10 milligram per week initially, and then 5 milligram per week. Low dose of steroid I often give in protracted courses like 7.5 or 10 milligram per day. So immunosuppressive agents is required when is not responding to the steroid. I often start the patient on mycophenolate meflotrexate and prednisolone straight away, and because these diseases are often chronic and they require long-term therapy. So dexamethasone intravitreal implant can be given. The implant is placed in the vitreous of the eye with a single-use applicator in sutureless. In the OPD or in the theater, it can be given. This is a case of 20-year-old female who has intermediate uveitis recurrent CME and treated with intravitreal Ozurdex, and the OCT thickness they will come from 600 micron to 170 micron, though the pressure was raised. So our experience of Ozurdex implant was found to be very useful in intermediate uveitis, controlling the inflammation and preventing the cystoid macular edema. This is a Ozurdex implant. Vitreoretinal surgery is required intractable vitreous inflammation, vitreous opacity, unresolved vitreous hemorrhage, retinal detachment, even in persistent cystoid macular edema. So it has been found that the increased incidence of remission was seen in the vitrectomized eye in intermediate uveitis. And this is a patient who did not respond to the topical systemic steroid and immunosuppressive agents, and vitrectomy was done for the dense vitreous opacity, and you can see that significant resolution of inflammation with improvement of the vitreous. One of the bugbear of intermediate uveitis is the cataract formation, which occurs 7.6% by 1 year and increasing to 36.6% by 10 years. And this cataract can be operated but wait for burnt out stage. 3 to 6 months minimum quiet eye is required. Preoperative topical, systemic, and periocular steroid should be given. IOL in the capsular bag, foldable IOL, and some cases may require vitrectomy combined, particularly there is a membrane in the pasternal region. Phacoemulsification with intraocular lens implantation in cases of pasternal is not without complication. Most frequent cause of poor visual recovery was CME, submacular fibrosis, and intermediate uveitis. I end with a case of recalcitrant intermediate uveitis. This is a patient, it's a 30-year-old male, was painless blurring of vision in the left eye for 2 months. Visual acuity was normal. Patient has significant vitreous opacity. I thought that this is an intermediate uveitis. I treated with microfilm, mofetil and oroster for 2 months, did not respond. I added biologic agents, did not respond. Then he decided to diagnostic and therapeutic vitrectomy. And vitreous cytopathology showed atypical round cells, and which was positive with showing a nuclear morphology suggestive of lymph malignancy. And these atypical cells are positive for B cell marker, BCL2, PAX5, MAM1, and KY67 proliferative indications 50 to 55%. T cell was negative, and this was the immunohistochemical marker of the vitrectomy specimen. Whole body PET scan was normal, MRI brain was normal. So in conclusion, intermediate uveitis is a quite common type of uveitis. Rule out TB and sarcoid in our country. In the elderly, keep primary vitreoretinal lymphoma in mind. Individualize the treatment because the pattern of changes varies from patient to patient.